Hey guys, welcome back. My name is Kelly. If you're new here, I'm a speech pathologist and I wanted to take some time today to answer some of your questions that I've been getting on the comments of my video or through Instagram. So today is just, we're gonna sit, chat. I've got a coffee, homemade cold brew, ready to go. I've got a couple questions to answer and that's all really that this video is gonna be. I figured that it would be better to like post a quick video about this versus just like commenting on people's posts, because some of these questions were kind of redundant or kind of similar to others. So I was like, we'll just go and post a video about it. So here we are, let's talk about it. All right, so let's jump right on into it. So the first question I got was, is your fellowship paid? So the clinical fellowship, I guess we want to talk about what it is first and the difference between that and grad school. So start off with grad school. Grad school, you do clinical rotations. Those are not paid for during your grad school. You actually pay tuition because they are credit hours. And then your last semester, how my program was set up, every program is different, but the last, thank goodness my air conditioning just turned off. The last semester of grad school, we did a full-time externship or internship at any facility that you wanted. So what that meant for me is that during that externship, when I was in grad school, I worked 40 hours a week at our university hospital. That was not paid for. So I know that some places like the VA, for an example, my friend made, I want to say maybe like $2 or $3 grand that semester when she did her externship in grad school at the VA. You can do your externship anywhere that your university has associations with, or our university even offered, like if we weren't associated with them and you got a position at somewhere else, then they could set up the process to get associated so you could complete your fellowship there or your externship there. That was not paid. Then once you graduate grad school, you start your clinical fellowship in speech pathology. Your clinical fellowship is either, the shortest you can complete it is 9 months. I completed mine in 9 months, and at that 9-month mark, once I met the requirements, then I applied for my CCC SLP license. As a clinical fellow, you work under a provisional license of a speech pathologist. So I had a mentor, a supervisor, whatever you want to call it. She was great, love her. And she signed off all of my paperwork. Everybody who I worked with like helped me out if I had questions at work, but that one coworker was my designated supervisor for my fellowship. It worked out really well because she was also my like clinical rotator supervisor when I was in grad school. So I went for my full-time internship that was not paid, got offered a position in that hospital that was paid as a job, and I worked under a provisional license with the same supervisor. It just worked out that way that we already knew each other really well. We shared an office together. Like, it just worked out that she would be my clinical, my speech pathology clinical fellowship supervisor. To answer the big question, your clinical fellowship is paid for. Like I said, we'll jump into that later, but your clinical fellowship is paid for. You are working under a provisional license. So you are a licensed professional. You are graduated from grad school. You get a job and you get paid. Some positions pay their clinical fellows less than a like CCC SLP, fully licensed speech pathologist, just because that's something that they can do. I didn't experience that necessarily, but I know a lot of people did during their clinical fellowship. I would say that like, if you're like, oh, that's unfair, like also think about it like if you were year one at another job, like in a different, I don't know, in business, for an example, like year one, you typically make less than like more senior people. Like that's just kind of how things work. Like out of grad school, you typically will make the least amount than you will ever make. And so that's just how it is. Like you make a little bit less as a clinical fellow. I think it's kind of annoying, but it is what it is. And so you get paid. You work, you get paid, you sign off on your notes. The clinical fellowship is paid for, thank the Lord, because you do a lot of work in grad school that is not paid for, that you actually pay tuition for. Alrighty, question number 2. Is it hard to get a medical SLP job right outside of grad school? So I would say I feel very fortunate that that's how it worked out for me. I also will say I definitely set myself up from even like my undergraduate experience to be a medical speech language pathologist. So for me, like, I was thinking, like, I was going into this field being like undergrad, I was doing undergraduate research in like swallowing, and with ALS and Parkinson's, I wrote a thesis paper in the cardiac ICU on the 3-ounce water swallow screen. Transitioned into grad school, I knew I wanted a lot of hands-on experience in grad school, so I worked with my clinical placement person who places you at all your different locations, and was very I advocated for myself to get medical placements, because I was like, I want to experience this. I want to see what it's like. I want to see different settings. I want to see different adults. I want to be like well equipped for when I apply for jobs, that like I will optimize my opportunity as a clinical fellow. Because to answer the question, from my experience and what I noticed with my friends who graduated from my program and like try to find medical jobs, I would say generally speaking, it's more difficult to get a medical SLP job than like working in the school or working at a pediatric outpatient clinic. One of the reasons I think that is because, one, hospitals or like medical placements, like when you're a clinical fellow, like I already explained, like you need a supervisor, like you need someone to sign off on your paperwork. And like I just think that hospitals are less willing to hire people who need that extra paperwork and extra help right out of grad school, versus someone who's a fully licensed speech pathologist doesn't need as much like help, because they don't need that person checking in on them every 3 months or every quarter and meeting and signing off paperwork and meeting requirements. Like that's just not something the licensed SLP has to go through. So like a hospital to hire a medical clinical fellow, like it's going to be more work, and they have to be willing to do that. Now, I will say that a lot of hospitals, especially university hospitals, when I was applying for jobs and interviewing, a lot of them have like that kind of support system up and running. I will say that the clinical fellowship position that I accepted at my first hospital was not an actual clinical fellowship position. So I would say if you are a strong student coming out of grad school, like, and you think you have the resources, and like you were super interested in getting a medical job, but all these postings online at the hospital is like blah blah blah, like only for licensed SLP, I would still apply and reach out to their department, because the position I took was not advertised as a clinical fellow position, but because I had rapport and a great experience and I already worked as a student there, they were willing to make that exception, because they knew I wasn't going to need like a ton of onboarding, a ton of training, because basically since I went from school working there 40 hours a week unpaid, I just kind of transitioned that position, like transitioned into that role once I got hired. So I would say that hospitals are very open to communicating that if there's like a strong applicant. I think that my hospital I'm working at right now, the girl who I worked with, like they hired her as a clinical fellow, even though they didn't have a clinical fellowship position. So like a similar situation, that some hospitals will be willing, depending on your experience, depending on what you're bringing, just like any other applicant. So I would always look out and be aware, but I also would say like tread on thin water, tread lightly. I don't know why I just said that. Tread lightly when you are like, if you're trying to apply for a job at a hospital, if they're hiring you as a clinical fellow, like make sure they have the supervision there to help you because you're gonna need help that year. And I would, use your best judgment if they're hiring you as a clinical fellow, and like they're like, you're just getting the vibes that like the supervision and the help that you need is not there, because then that fellowship experience is not going to be like setting you up for success. Like that really is the last opportunity that you have to like have someone that like is kind of forced by requirement to check in on you, versus like from there on out, like your coworkers don't really need to check in on you. They should, but like they don't need to. Another note about like medical speech pathology and like getting a job like as a clinical fellow, I would encourage like any person coming out of grad school, like if you can't find a hospital job, like if hospitals aren't hiring you, like think outside the box. So like medical speech pathology goes outside of just working in like the ICU and like in acute care setting. Like you can be a medical speech pathologist and work in an outpatient clinic. Like I do a lot of medical stuff when I help my outpatients. Another placement that I loved when I was working in grad school and was not in a hospital at all was an outpatient like neuromuscular clinic. So we did swallowing therapy, evaluations, communication, AAC devices, respiratory muscle strength training. There goes my AC again. All of this great like hands-on stuff, but with patients who have like Parkinson's, ataxia, PSP, ALS, all of these movement disorders that impact speech and swallowing, and I loved that placement. So it was very medically based, even though I wasn't working in a hospital, and I would really encourage people to think about working at a place like that, working at an outpatient clinic if they can't get a medical speech pathology placement as a clinical fellow. Because if you can get another job like long-term acute care, and then you can transition to a hospital once you have your Cs. There's other ways to work around it, and I wouldn't be necessarily like completely discouraged if like you don't get a clinical fellowship placement. In a hospital, there's other opportunities that you can still do medical speech pathology stuff and then take CEUs, and then once you have your Cs, apply for the hospital if that's really where you think you want to be. That's my tangent. Alrighty. Let's get on to this. I don't know what's going on here on my forehead. Anyways, last question. I'm gonna take a sip of coffee because I've been talking, and even though this is not gonna hydrate my vocal folds, here's some coffee. Whew, that's strong. Okay, so I thought this was an interesting question, and I kind of wanted to address it more, and I hope that the girl who I messaged on Instagram back like listens to this, because I feel like I could only express so much like via text message or like via messaging, and it's so much easier to explain it like in full conversation. But basically she was between nursing and like pursuing speech pathology, and was very curious about the different equipment speech pathology versus nurses use. She's wondering what kind of equipment you deal with in the hospital on a daily basis. So I would say I'm definitely not a nurse, which is a very funny like side tangent joke with Jonathan's family. I'm not a nurse, so I can't speak of like all of the equipment nurses are trained on, and I think that different nurse specialties are definitely more equipped in different equipment, known to use different equipment better. I don't know, like it depends on their specialty. But so I really only want to touch on like the speech side of like the SLP side of things in the hospital and the equipment we use, and like the overlap with nursing using that equipment. So I would say like base equipment that anybody who's working with a patient in the hospital is gonna be aware of is their Tele box. Let me pull up a photo of that. Okay. So, oh God. Okay, if you can see this is kind of like what a tele monitor, a tele box, whatever you want to call it, like will look like. And I would say that this is important for literally anybody touching a patient in the hospital, especially in the ICUs. Now, in step down units like med surg units, our patients won't always be monitored by a tele, but if they're being monitored by a tele, it's something that no matter what discipline you're going to be in, you're going to be kind of aware of those vitals. The different vitals that are on that machine is blood oxygen level, your heart rate, and your respiratory rate. So different things. Oh, also like your blood pressure will get taken, and like the blood pressure cuff will go on and it'll pop up on the screen. So all these different vitals that It's important to monitor whether you're wondering if your patient's hypoxic, hypercapnic, if they're tachypnic, tachycardic, like all these medical terms, like that telebox is gonna, if their vitals are jumping all around, you're gonna be like, we need to address this. Or me as a speech pathologist, I'm gonna be pulling in the nurse and being like, is this something that's like new? Like, why is this patient acting like this? Like, this is not how I saw them yesterday. Why are they looking like this? Or if they're improving, like their vitals are gonna look better. So vitals are super important for both nurses and SLPs or PTs or doctors or anybody really touching a patient. Another thing that a speech pathologist typically uses is a X-ray swallow study. Okay. Shout out to Healthline for this photo. So as a speech pathologist, one of my favorite things to do is modified barium swallow studies. So this is a moving X-ray in radiology. Nurses don't do this, so you have to have the competencies in order to do this. But it's our way, one of our ways to objectively measure the oral pharyngeal swallow function. And then we typically do an esophageal scan if we can manipulate the patient to do that. Sorry, I'm just looking up another thing. So this modified barium swallow study, like I said, it's a moving X-ray procedure that we take the patient down. If they're an ICU level patient or an IMC, like their nurse will come down with them. If they're on the floor, then they just arrive, transport brings them down, and we can see what's going on with their swallow. So are they having things travel into their airway? Are they aspirating? Or do they have efficiency? Do they have a lot of residue in their throat? What strategies can we help them? All of the things that I'm going to determine whether they can eat a diet, what's the safest diet they can eat, how do they need swallow therapy, what are we going to target in swallow therapy, all of the stuff that like looks at the whole picture of the patient, I'm going to be doing that test. Nurses do not do that test. I love this part of my job. I think it's the most interesting part of my job. So that's a huge SLP thing. Another huge SLP thing is a FEES, a fiber optic endoscopic evaluation of swallowing. What it is we pass a camera through the nose and it travels down and takes a look at the swallow from a bird's eye view camera perspective. This is another way we can, quote, objectively measure the oral pharyngeal swallow. It also gives us a look at the anatomy from a camera perspective. So shout out to a speech swallowing LLC specialist, but here is a picture of your vocal cords. Oh my gosh, the glare. Okay, vocal cords. So vocal cord, that's your airway. This is your epiglottis. So this study looks at swallowing from that perspective. So we can't diagnose different like pathologies when it comes to your anatomy, but we can definitely send these photos and say, hey, we need to contact an ear, nose, and throat because this is not looking like we want it to look like. And then the ear, nose, and throat doctor does their scope and can diagnose, like, are they having a vocal polyp? Are their vocal folds not moving together? Is one just stuck? Different things like that. I am personally not trained in FEES. That is something that is in the plan, in the works to get me up and running for it. So it's not something I'm doing right now. But as a graduate student, I had a lot of experience in helping out. So the speech pathologist will pass a scope in their nose. Nurses do not do that. The nurse does help us though a ton in that study, because if you're on your own with the patient and you don't have a student, like someone needs to feed the patient. So we feed them like Gatorade and applesauce and we can watch all that stuff go down. Again, we're looking at, is there residue? Is there things traveling into the airway? Are they aspirating? So two main things that the speech pathologist, like huge medical devices that the speech pathologist uses that the nursing staff will never really touch. All right, so I could go on a long rant about like different medical equipment that the speech pathologist uses, for whether it's for therapy, whether it's for voice. Like I I think that depends on what you're doing with your patient, like why are you seeing them, what kind of therapy you're providing, or what kind of evaluation. Like voice therapy has a lot of things on the computer that a speech pathologist is going to use that like I will never really use in, I guess, like medical acute. But like there's something called a stroboscopy, and that's a different type, that scope in your nose I was talking about. That's a different type of scope that looks at the vocal folds moving under like a strobe light, so you can look at different movement patterns. Something that, again, will be done in the hospital. It's just not as common. I will talk about one device. I'm going to talk about two more devices because this one is great, and then there's another one that is great too. And I'm going to limit to just two. Okay, so then we have the expiratory muscle strength training device, the EMST 150. So this little device is a muscle strength trainer for your expiratory muscle, to improve your expiratory muscle strength. What that really means is, why is that important? My air conditioning. Why is that important for the speech pathologist? It's important because a lot of research suggests and supports that this improves cough function, it improves swallow, speech, muscle strength training up in your throat, your soft palate. There's a ton of research behind this, and training it by the rule of 5 sets of repetition, 5 days a week, five sets of repetition, 5 times a day, 5 days a week. I love EMST. I train a lot of my patients on it from an outpatient perspective too. This is huge for our ALS and Parkinson's patients, that there's tons of research behind that. I would read any of Dr. Plowman's studies on that because it's huge. I would say that Dr. Hutchinson has done a ton of expiratory muscle strength training in head and neck cancer, so another population that's popular. I would say a lot of other evidence-based like uses of EMST are definitely out there, and that I would highly recommend if you don't have EMST at your hospital, like a way for you to train your patients on it and then start therapy with it and like bill them for it, because a ton of research suggests the value and the importance of EMST, and I think that if it's evidence-based, then let's do it and let's get our patients help. And it's very tangible and very, I would say, easy to do in comparison to other things that there's an auditory feedback if you're done the repetition correctly, versus like effortful swallows. Like I do a lot of effortful swallows with my swallow therapy patients, but like I can't measure if they're actually swallowing with effortfulness. Like EMST, I'm like, these are what your numbers should be at, this is what we're training you at, I calibrated it like this, and let's go. Now there are some patients where EMST may not be appropriate. Again, I'm not gonna do a whole training on EMST right now and like patients that are appropriate or not, and like how to calibrate the device, but I would say like if you're working in the hospital and you're interested in like helping your patients or an outpatient clinic, definitely look into EMST and the evidence behind that and how it can help our patients. All right, so I promised one last one. The IOP device, the Iowa Intraoral Pressure Instrument, question mark? If I remember correctly, that's what it is. The IOP is a bulb. It's a pressured bulb that goes in your mouth and that the patient can push up on, and then this device reads the pressure that is provided onto the bulb by the force of the tongue or the muscles. I would say IOP, again, head and neck cancer patients, IOP to strengthen those tongue muscles. Definitely if they've gone through chemo, radiation, or any kind of lingual resection or reconstruction, IOP is huge. I would also say other patients that are having some neurodegenerate diseases, IOP, and training on IOP and looking into the evidence-based practice behind that, because again, it's a the patient, you take some measures, you take a percentage of their max measures, and then you start training them on that. And that device has a light that will like read and light up green, read the pressure buildup, and then the device light goes at green, and so it's giving them feedback like you're hitting your target, you're squeezing hard enough, you're not squeezing hard enough. Like, again, a very tangible device that you can actually measure like what the output is. I really like if we're concerned about tongue strength or for speech or swallowing. I'm not going to go too deep into that because the IOP device, I would say, maybe even more rare than like the EMST device for a hospital, but I would say it's a very like evidence-based in specific populations and very easy and tangible to start like implementing into appropriate patients that could help them. Those are just like a little bit of a rant about medical devices that speech pathologists use. I would say when we're talking about any patient in the hospital, like patients are going to be on ECMO, the patients are going to have dialysis in their room, and like you need to know, or like patients' lines, like what's strapped to their neck, and if they have a central line, like what that means and all that stuff. Like you have to be aware and have a general knowledge of all of that stuff. Like the different respiratory masks, and they're different, like are they on a high flow nasal cannula, normal nasal cannula, what if they're on BiPAP, are we going to touch them, all of the other stuff that like other specialties, like we don't need to know how to. I will never calibrate like whether I should be putting on a patient on BiPAP, like that's not my scope of practice at all. That's respiratory 100%, but like I need to know what a BiPAP machine is, and that I would not feed my patient when they're on BiPAP. Or if they're getting dialysis, like there's going to be a dialysis nurse in their IC room with them while they're going through dialysis and like getting that done. But like I'm not going to ever touch the dialysis device, but I need to know that they're on dialysis and what that means when it comes to how it's going to affect their speech and swallow, how it's going to affect their alertness, how it's going to impact like their positioning in bed and not screwing up the dialysis lines. So I would say that like even though I just went through like a couple of different things that like the speech pathologist specifically will like work on and like is our expertise, that does not mean that like there's other medical devices that you need to have a general knowledge of and like understanding what it is and like to do your job and like keep the patient safe and not also like interrupt like other people's treatments. So looking at the whole picture, like even though I'm not an expertise in a lot of other devices, like I need to know what they are in order to properly care for my patients. So I hope you liked question time with Kelly. If you have any other questions about speech pathologies, please comment them down below. This was like super easy and super fun for me to just like provide some education and ramble about some stuff of the hospital and the fellowship year. But that's really all I got for today. Told you, question answer, rapid fire, a couple of minutes. Yeah. Woo, all done. So thank you so much for watching. I'll see you next time. Keep up with my videos, comment down below, and please subscribe.